you, Professor Lee. Thank you very much for your wonderful speech, and thank you for your share your great idea uh, about the pedicle screw incision assistant with UB technique. It's a great idea, I think. So next, let's turn to the next section. The next section moderator is Professor Liu Zhen from Beijing, China. Welcome, Professor Liu Zhen, to host the next section. Thank you. Thank you all.
Thanks, Professor Deng. Okay, let's continue. Hello, Professor, colleagues. I'm Dr. Liu Zhen from Peking Hospital, Shougang University. Shougang Hospital, sorry, from China. It's my honor to join this conference. Let's welcome the first speaker, Dr. Henry DiMano. Henry DiMano. His topic is UB spine surgery in a third world district hospital setting, pros and pitfalls of introducing disruptive technologies to communities in need. Welcome, Dr. Henry DiMano.
Hello, sir. Thank you very much for having me. Thank you to ISUBE. Let me share my screen. Okay.
We can see your screen.
Okay, thank you very much. Okay, I'll start, sir. Hello, I'm Dr. Henry DiMano. I'm from the Philippines, as mentioned. I just want to address the audience. My talk is specifically for certain types of surgeons beginning their UBE practice. If you're the kind of surgeon who is situated in a first world or developed country, if you are in a big hospital, whether government or private, if you have all the equipment you need in UBESS, and if the place that you do your surgery actually welcomes endoscopic spine procedures, okay, if your OR staff is already trained, you have all the nurses and assistants that you need. If you practice at the center of high technology in spine, you are a center of excellence. If your patients don't have to worry about their funds or how to acquire services for spine surgery, and if let's say on some of the surgeons, if they still prefer to use fusion-based surgery in patients, open surgery, I mean, this lecture I'm going to present might not exactly be up your alley. However, let me also qualify that if you want to bring the technology of UBE or endoscopic surgery to the masses, to the periphery, or if you want to serve an underserved community, or if you like the challenge of making innovations because you need to, if you want to work in a system that can only give you the bare minimum, as we do here, if you like teaching and sharing that knowledge, and if you are okay with less than ideal settings, if you want to find treatment for your patients who cannot afford the surgery, and if you're open-minded enough to explore the alternative, of course, of UBE surgery, then this might actually be for you. So let me continue sharing. Just a quick view. I've been an orthopedic. I've been a doctor since 1999. I actually studied in a government institution in the Philippines in the National Capital Region. I shifted to. I first started neurosurgery, but after about a year, I went to general surgery in a private hospital. It makes a big difference in the Philippines whether you're in government or private. So I said I wanted to do private. I went into orthopedics 3 years later, also in a private hospital, and I graduated in 2007. Going on, I first started learning spine surgery from Dr. Richard Condor, my first mentor, in 2009 to 2011. So the surgeries we were doing were largely fusion-based surgery, T-lifts in particular for the lumbar spine. I did not find endoscopic surgery until 10 years later when Dr. Daejun Choi visited the Philippines in February 2019. And I eventually ended up training under Dr. Chulwong Park in South Korea just before COVID outbreak. So I actually nearly got locked in there. Okay, going on. I mentioned disruptive innovations. I'd like to qualify my definition for that. For most of the developed countries, I guess UBE is not a disruptive innovation because it's already mainstream. You have already accepted it as part of your services for your patients. But here in the Philippines, we hardly see endoscopic spine surgery anywhere. So just as a definition, I get this term from Professor Clayton Christensen. He basically said that disruptive technologies are not really new. They've been around. It's just that some people sometimes start thinking of new ways to use old technology. And he also said that initially you only use this technology in the low-end markets by unsophisticated customers, or in this case, our patients who are generally low demand. Okay, more so, he made this diagram. So he was saying that because of the high specialization of medical services, we tend to gravitate towards the centers, the large centers of medical care, big hospitals in big cities where you have everything you need. You have all the technology. So you have a larger portion of the population that is at the periphery and probably will have a difficult time getting here, either because it's too far away or because they can't afford it in some ways. If your medical system provides everything for everybody, well and good, but not all medical systems are able to do this. So he said, at some point, you have to bring out the technology to benefit all the other people in the periphery, so that everyone can experience this or can benefit from what you know. Okay, he said disruptive innovation or disruptive technology isn't really a breakthrough improvement. There's nothing groundbreaking about it. But rather what it does is it changes what is already existing that is complicated and expensive into something that is affordable and simple. And furthermore, he said that rather than expecting the health system to become cheap, the providers to bring down prices, we need to bring the technology outside of where it's usually high cost and go to the lower cost venues of care or the lower cost caregivers in order to service the patients. So we want to, as much as possible, get wide adoption of the technology, in other words. Just as an introduction for those who don't know where we are, this is the Philippines over here. We are far away from the more developed countries. We're in Southeast Asia. We have a lot of islands, 7,101 islands in 3 regions. More than 112 million people. Our land area is just about as big as Turkey, but we are about 3 times more in terms of population density. And in the last 2 years, we've been hit pretty hard by COVID. We've had 4 surges, and our economy is really shot as of this point. So here we are. Let me show you. We have 3 regions here: Luzon, Visayas, and Mindanao. And for each region, there's a basic hub, I guess the metro. Metro Manila is the national capital as well as the capital of Luzon. Then you have Cebu and Davao in the other areas. So there are a lot of people in the outer islands that will all need to come to the major cities if they need anything that is highly advanced. Okay, so again, this is your centers over here. I am now currently practicing UBE surgery in this area of the Davao region. The province is called Misamis. So mostly the advanced technology is here, and this is like a whole day of land travel if you were to travel by land. It's very far away due to the conditions that we have there. But I practice out of this city over here, small one. So that's the province, and I'm here. So I usually service this part of the province. Okay, in the Philippines, you have big government centers, big private centers, smaller hospitals. I just run through this just to get you acquainted. Usually the population, the bigger or the major the population, the bigger the hospital. You have subspecialty and specialty services in the big centers, but normally in the smaller centers, you may have specialty care, general surgery, internal medicine, pediatrics, and OB-GYN, but there might not be subspecialists in these areas. The practice in the Philippines is if it's a private center, the patient generally shoulders the cost of care. There's a national insurance, but it's not much. And sometimes there are private insurance or health maintenance organizations, again, not much. In government, generally the poorer patients go to government centers because the healthcare is for free. Okay, the doctors are paid per patient in the private centers, but in government, the doctor is paid a salary by the hospital or by the local government or by the country. Okay, so basically we have enough doctors in the private centers. The smaller private centers, you will have lesser patients, of course, because there are lesser beds. But in a government center, you have very many patients because, again, a lot of people cannot afford the private sector. Okay. Now, how about our hospital where I'm doing UPE right now? It's a small government district hospital in the periphery with only the basic specialties because it's government. The government pays for everything. Okay, we have a lot of patients there, but before we started practicing subspecialty, you had to refer a lot of the patients to the big government center because you did not have technology here. Okay, you can't refer them to the private hospitals because otherwise they won't be able to afford it. Okay, can you do UBE surgery or is endoscopic spine surgery being done in the Philippines? There are few centers that actually have already started or are already featuring Uniportal endoscopic surgery. In Metro Manila, I know of only one hospital that has a doctor that knows, one big hospital that has a doctor who can practice UBE surgery. And then of course there's me. I don't know how many other doctors actually practice it or have started practicing it. Okay, in the small private hospital in Metro Manila where I work, we introduced this in 2020 at the height of the COVID season because we wanted to keep patients as short stay as possible. So this is the hospital where I do it there. It's private, and luckily they adopted it. I offered the technology to several hospitals. There were no takers from the start. So they don't find it attractive. I don't know why. Okay, so why bring it to the small district hospital? Because number one, it presents access point to the patient. There are a lot of patients that will go here first before they can make it to the big city. Number two, patients can easily afford the services here. You can decongest the big hospitals. Instead of them flocking over to the big government hospitals, they can already get surgery or services at this point. UBE can save a lot of patients from early fusion. Why do I say this? Because a lot of the big hospitals only offer fusion surgery instead of the more minimally invasive approach. So basically, you can select your patients. You don't have to fuse everybody. There are patients who are stable to begin with and do not present with conditions that will require fusion. If you do UBE, of course, there's no need for fusion. They can get fusion later if they really need to, once they've saved up for it, because as I said, it's expensive. So it's a matter of patient selection. But if you go to a big hospital, it's probably going to be a recommendation of fusion. One big advantage in a small hospital is that UBE requires more affordable instruments than Uniportal system. So you can easily set it up. You can get the instruments that you need and start doing surgery if you have a surgeon who can do it there. So that's one attractive feature of UBE. Okay, right now in this particular region, as far as I can tell, we are the only hospital here, a small one, that actually offers UBE surgery. So that might be fascinating for people living in countries that have a lot of hospitals that do endoscopic spine. But we were very much behind in terms of adopting endoscopic surgery in our country. So this is the hospital. It's really simple, very basic services other than the subspecialty orthopedic that we offer there. Okay. Okay, so why has it been slow as far as the whole country is concerned? Why not adopt endoscopic spine surgery? For one thing, very few subspecialists are practicing, and they usually practice in the big cities, and they will find it not attractive to go to the faraway places. Okay, no trained personnel in certain hospitals, so that means you have to teach personnel in order to support you, people in the OR, for instance. Okay, usually there are no dedicated operating rooms for minimally invasive procedures or even spine procedures. It's expensive to buy equipment, in my country. No distinction between open spine surgery and endoscopic technique. In my country, we use the same RVU code, same CPT-10 code. So it's not attractive for hospitals to adopt endoscopic spine. One issue, of course, is that the implants are a major driver of the practice. So if you do surgery that doesn't need implants that much, then it might reduce your revenue. And this is a big consideration, especially for private hospitals. Okay, so I've offered this to several hospitals. Sometimes a hospital administrator will say that it's too expensive or experimental. They don't even know anything about spine endoscopy. They think it's a brand new thing. So they usually get surprised when I tell them that it's been around since the 1970s, evolved through the 1990s, and biportal endoscopy has been around since the turn of the millennium in the early 2000s. Okay, one major spine surgeon in my community even said that he doesn't actually know anything about it. So it's a matter of spreading the word. A lot of people don't know much about it, and so they think they take it for granted. In other words, there is a lack of awareness in my setting. There's still that prevailing perception that the only thing you can do with spine endoscopy is just a limited discectomy, and that there's not much to be had if you're a private institution. There's little profit from it. They do not know this history, the whole idea of the development of endoscopic spine technology, all the way from uniportal techniques all the way to biportal techniques. And we're just trying to introduce that now, get people to know what the history of endoscopic spine surgery is about. Also, it helps that nowadays we are starting to see a lot of journal articles on biportal endoscopic surgery, because in the beginning there were very few to read. So now we are starting to become more aware. Okay, to a great deal, I guess surgeons are still used to seeing their operative site this way. The idea, the concept that you can use a camera and that you don't need to open up the skin so big is still a bit foreign, still a bit strange to a lot of surgeons who have been used to doing spine surgery. This is a very strange view for somebody who has never had the chance to actually do endoscopic surgery. Okay, so in our institutions, the obstacles we encounter, and I hope you don't get shocked by this, we have a brand new C-arm, yes, and a table, but we don't have an endoscopy tower. We don't have the usual machinery that you use. We don't have an RF machine. We don't have the fancy burrs and drills in our institution. The medical facility, the whole province has no hospital that has an MRI center. So we have to send our patients to the next province in order to get scanned. And this is a major delay for diagnosing patients. OR nurses are not trained for specific types of surgery, so you have to train them, from the ground up, from scratch. So these are the main obstacles. We started training them. Actually, I first introduced knee arthroscopy so that they would get used to the idea of what is endoscopic or arthroscopic surgery. And once they get started with that, then transitioning to spine is not so difficult. Okay, this is a video of which shows basically the equipment that we've been using. We use a standard scope, but we've had to make use of, since we don't have an endoscope tower, we have to make use of computers and LCD screens. For doing drilling, we basically use a makeshift burr fitted with a surgical burr tip, surgical drill. So you basically can use it in much the same way as you would an arthroscopic shaver. This is actually that device at work. This is a surgical burr. It does the same job, maybe a bit slower. Okay, let me fast forward a bit. I've had to use arthroscopic drills, but since we don't have the machine, you can fit them in a hand drill. Remember, it's so difficult to get the equipment to where you need it, but it can be used. Again, same burr tip fitted to a hand drill. This is a ULBD procedure that I did in the government hospital, so it can be used. It's just you just have to adapt things. Cautery, no radiofrequency ablator, but if you're used to using a standard bipolar cautery tip, we've actually adapted this for use in spine work. Again, it's very expensive to get the equipment, so we make do with what we have. So it works as you would expect. For bone bleeding, we basically just put pressure on the bleed like this, using either a Kerrison or your curette to stop the bleeding. I've actually adapted the uniportal cautery tips so that you can use them in a biportal setting. Do they work? Yes, they work. They work just the same. So we can do the same procedures. Okay. Moving on. Standard open spine instruments are readily available, thank God. Scope, sorry. This is the set of equipment that I showed you a while back. Sometimes I use plastic trocars for nerve retraction, if not the steel or metallic trocars. So basically, the whole idea is you can fit everything in a suitcase and go to a hospital far, far away, and you're ready to go. All the equipment you need can fit a single compartment, as long as you have the equipment there in the hospital, a C-arm or an X-ray, you can go ahead and do your thing. Okay, so most of them, we've basically found a way to go around some of these problems. One of the major things is still the lack of an MRI facility. We will have to wait until the province eventually finds a way to invest in that. But this is the setting we have in our government hospital. If not just a laptop, we fit it to a big screen so that we get the feel of an endoscope tower. Standard saline, standard endoscope. The only difference is the camera that we're using. It's still high def, so it's okay. Sorry, this is a standard discectomy that I've shown to some people in the same hospital. Let me fast forward. So it's the usual approach wherein you do your laminotomy, you take out the flavum, control the bleeders, and do your discectomy. So here I'm using a big screen. Actually, this is the laptop that's connected to a big screen. And so before we came to the center, no one actually offered any kind of spine service at all. Luckily, we are now able to do these procedures. Okay, we are now doing them under epidural anesthesia, so the patients are actually awake when we do them. This is that patient that you were seeing a while back. There's another patient which I did in the small private hospital where I started UBE surgery. So very good results. Their symptoms resolved the following morning, and we can discharge them early, and they are happy because they are no longer in pain. The only difference between a small private hospital and a government district hospital is that there's hardly any cost to the patient in this institution. Here, the patient has to pay for everything. Okay, I will skip this part. So we basically have managed to at least bring the technology to one government hospital in the periphery, a small one at that. And usually people can't believe that we can actually do such surgery in a small center. But this is where a majority of the patients who need it go. Patients who could not afford in a private hospital. In a government hospital, profit is not an issue. You know, the hospital is subsidized by the government, so it doesn't need to make extra money. That's not the goal. Return of investment is not a main goal. The main obstacles here will be equipment and people to actually help do the procedures. Okay, some pitfalls of bringing this technology to the periphery. You have to, of course, have the patience to teach your nurses, your other OR staff, the administrators. You have to orient them what is endoscopic spine and what do we expect for how we go about our surgeries. You have to make do. You have to innovate. Sometimes you have to make use of what is locally available in order to get your service up and running. You want to travel outside. It's going to involve the doctors or the specialists actually traveling to faraway places. So if you're comfortable in a big center where you train, for those who would rather stay here in the big hospital, this might not be the work that you would want to do. Okay, definitely, if you just started your UBE practice, probably you wouldn't want to be doing it in a center that is rather challenging and less than ideal. Okay, you don't expect to get rich here. This whole government, and actually, patients are not required to pay us doctors, but sometimes they give us gifts. So expect to be given something like a bucket of shrimp or rice cakes, or one time a patient gave us a microwave oven. Thank you for that. Okay. And of course, my biggest obstacle here is that the established practice will tend to downgrade whatever it is you're trying to do. The industry leaders will think that you're either doing something crazy or you're doing something that they don't like or such and such. But I guess in any country, in any hospital that started to adopt endoscopic spine and UBE in particular, I'm sure you've encountered this wherein, you know, some of the fellow doctors might have been skeptical about what you were trying to do and not actually believe that it could be done. Okay, some pearls, I guess it is near the end of my slide. So some pearls that I'd like to share. You need to prove to the hospital that such technology can be brought to it and that you can execute it instead of just waiting for the hospital to call you and tell you, can you start this here? You have to take the initiative if you're the one who wants to push for the technology. The whole idea is to provide service to the underserved. Also, if you think about it, any kind of technology that starts out like this will have to start from the bottom going up. There are already people, you know, patients who have high demands and who will probably need to be here in this area. But if you think about it, there are a lot of people in the periphery that don't get these kinds of services. So the goal here is to bring the services to them and then hopefully may establish centers in the periphery. But you have to start somewhere. Okay, one of the things we realized is that because of the less than ideal situations, you have to innovate. You have to find creative ways to attack a problem. Sometimes you stumble upon something that will help you become more efficient. And I guess a lot of innovation is like that. It's trial and error, but you get to the point where you can actually deliver the service. And lastly, I hope to share this for the orthopedic people in the group. Is Dr. Ramon Bustillo. He was my department head when I was in residency. He's still practicing today. He's a 90-year-old surgeon, innovator, implant inventor, who basically told me that innovation, it's a natural part of the process, and it's naturally disruptive. And his idea is that just focus on doing a good job, and you'll be able to deliver the service. So a lot of thanks to everyone who developed the technology, because without the disruptive innovations of all of these people and even more who are not in this slide, we wouldn't have been able to achieve or come to where we are now in terms of UBE. Okay, so initially the plan here was in the beginning when I was transitioning, I just said I'm going to stop doing the open surgeries and transition to endoscopic surgery. But in reality, what happened was it was a really roundabout way of getting about things. It was harder than I expected, but eventually we were able to bring the technology somewhere. We're hoping to do more of this in other centers, in other small government hospitals, wherever the need is. Show them that you can bring this technology out there. And it doesn't have to just serve a small number of people in the population. It can be for everybody. So why do we need to do this? Because it's what is needed. There are patients who need it, and we believe the necessity is what will drive this service to become what it is in your countries, hopefully. So thank you very much. That's the last piece of slide I have.
Thanks, Dr. Henry DeMano, for the wonderful presentation. UB is really a practical, popular, and easy to achieve the technology. Thanks again.
Thank you.
Now welcome next speaker, Dr. Malcolm Patoji from India. He is the chairman and founder of Endoscopic Spine Foundation India. His topic is posterior cervical UB. Welcome, Professor Malcolm Patoji. Oh, I see you.
Yes. And,
yeah.
Hi, can you see me?
Yes, very clear. And
just 1 second, please. Yeah, thank you. I'll play my presentation now. Now, can you see the screen, please?
Yes.
Hello. Yeah, sorry, I was busy in the theater doing one case right now. I'm making my presentation is on how do I do it series of mine, and that is I'm going to talk today cervical UB. It's a very simple presentation, but we start with it. Now, what are the indications and the principles behind a cervical UB. Basically, the cervical UB is for posterior paracentral disc herniations, disc osteophytic complexes from the posterolateral corners, causing narrowing of the outlet of the nerve root and severe radiculopathy. And now the things have been extended into single or even multiple levels, cervical myelopathy. And my contemporary and dear friend V. Zhang must have spoken about it or will be speaking about it. It's basically a motion preserving surgery, and there is an extremely low likelihood of any adjacent disc disease developing after this surgery. So that is the advantage. Unlike the Schofield approach, which was formerly taken for posterior foraminotomies, there was almost a 40% incidence of permanent neck pain because of muscle trauma. And this is a recorded fact with the Schofield approach. And UB obviates all that. There's 2 small cuts on the neck. You're not stripping the muscles. You're only dilating a path over there. So the patient does not really suffer from postoperative neck pain. That is the advantage. Now, how do we do it? The landmark is basically the uncinate process. Now, why is this uncinate process such a key landmark? Lateral to it is the vertebral artery, but medially, it demarcates the extent of the cervical disc. Now, when it demarcates the extent of the cervical disc, obviously any posterolateral herniation that is going to come out over there is going to come out maybe 4, 5, 6 millimeters beyond that. Nothing more. So what do you need to do? You need to decompress lateral to the uncinate process from where the root is going by about 5 or 6 millimeters. So the uncinate process, when you see it in an AP on a C-arm, which is the image I'm showing you, that defines the lateralmost extent of the cervical disc. All paracentral herniations will occur at this point, including the disc osteophytic complexes which grow with age. And exploring a nerve root is usually lateral to this point. Canal entry is very safe at this point because you are lateral to the central pylon. You are not going to hit the central cord. So therefore, it forms a very important landmark when you want to do a cervical UB. How do I do it? I position the patient in a jackknife position. You can see the image over here. The neck is always parallel to the floor. Many surgeons make the mistake of keeping the head down. Now, when the head is down, your working angles are going to be very oblique. And you're going to be very uncomfortable over 2-3 hours in case you are in some trouble. So you want your angles to be straight. Now, when your angles are straight, your working is faster. You can finish the surgery normally in about 40 minutes. So the advantage of this positioning is that the neck is horizontal to the floor. Hence, the working and scopic portals are upright and comfortable. There is a strap on the buttock which I have put to make sure that the patient doesn't slip down. There are straps to pull the shoulders down, the knees are bent, and a body warmer keeps the patient warm. Now we come to the skin markings. The first line is always the midline. Mark the midline, see the lateral masses equally, see the uncinate processes equally. Do not work in a rotated neck. You will always be in trouble. You may miss your mark. The second line is the outer pedicular line or the outer facetal mark line. Why I want to know that is I want to know, okay, where am I supposed to land? I'm supposed to land medial to this. The third line is a mark line which is almost a centimeter out. Now I take my skin incisions here and I take a 30 degrees oblique trajectory to land directly on the facet. From landing on the facet or on the lateral mass, I start stripping the tissues there along the lamina and then search for my V spot. Now, where do I put in my needles? If I'm going to operate here, as in this particular case here, I'm operating at, I think, C4-5. Then I'm going to come from above the lateral mass and I'm going to come from below the lateral mass. So I'm going to get a skin distance of almost 3 centimeters apart. My scope and my instruments will not clash. This is a very basic approach. This is a very basic marking. And in any person who wants to do cervical UB, he cannot do it if he does not follow this. Keeping the neck straight or in slight flexion opens up the interlaminar space, will prevent shingling of the lamina, will allow you an entry with a 2 millimeter punch very easily. Okay. Now, so I've explained to you the line 4 and the line 5, which are the trajectory lines. Okay. Now, always do a lateral check. Whenever you're going to do a cervical UB, please do a lateral check. confirm your level. Make sure you're at the damn right level. Otherwise, you're going to ask for trouble. Here, you see what I've done on table. I've put in a dissector. I've marked the center. I am marking the B point where I wish to land. This is the scopic portal. I'm triangulating that now with the needle from below. So I'm landing with my instrument portal. After that, when I'm inside, when I've done the basic stripping, I take one more CM shoot. When I'm in the V spot, I want to confirm that I'm in the V spot. Here you can see very nicely that I'm sitting in the V spot. My scope is on the lateral mass. I know exactly now, if I start cutting from this point up to my scope, I am not going to massively disturb the facets. I'm going to preserve the integrity of the facet, and we're going to be able to do a good job. Okay. This shows you the entry into the axilla and into the disc with a 2 mm punch. I'm grabbing a fragment, I'm removing a fragment. Now I'm going to play a small video, which I want you all to see carefully. A small video on how do I do it. Expose the lamina, expose the spinal lamina junction, come laterally onto the facet joint. Step 2, identify the V junction, identify the SAP and the IAP, where they meet, and identify the laminas. We are right now at the V junction. Stripping away some tissue, exposing the phlegm. Confirm your position on a C-arm. And start burring away the lamina, the facet joint. Determine up to a lateral extent that you wish to go. Below you can see that we are burring away and thinning away the SAP. Proximally we were cutting away the IAP. Identify the edge of the SAP towards the canal. Strip away the tissues. And with a very small 1 mm kerosene, start the process of decompression. As you come laterally, you will see the dural edge and the bulging disc in the axilla. The traversing route and the bulge of the disc is clearly visible at this early stage of decompression itself. The exiting route is here. Where I nibble away, now you will be able to see the exiting route. Identifying the exiting route, delineating the axilla completely is essential to starting the decompression of the disc. As you can see now, the exiting route, the traversing route, both are open. Removal of the fragment from the axilla. Using a small grasper. What you see here is the pedicle and the root going beyond the pedicle. This is the root going beyond the pedicle. This is the pedicular wall. And now teasing out the main fragment. You can now see the complete route as it sweeps out through the foramen. Nicely decompressed, little laminectomy and a little phlebectomy towards the midline cord, decompressing the entire cervical canal, introducing a drain so that I prevent an epidural hematoma formation. You can see the root sweeping around the pedicle and exiting the foramen. They are both sweeping around the pedicle here. I thank you very much for your patience and kindness. Thank you. You are now seeing the post-operative result of the decompression. You can see in the axial that we have cut a small amount of the lamina. We have undercut the facet, retained the integrity of the facet joint to a large extent, and the surgery is over. Thank you very much. This has been a small and a sweet presentation. I hope you all have enjoyed it.
Thanks, Dr. Malcolm Pastogi. Thanks for the wonderful presentation. If any questions, please record it and we will discuss it later. Or send the questions to the Zoom platform and leave your email. We will contact you. Now let's welcome the next speaker, Dr. Abdullah Mustafa. Thanks.
Bye-bye.
Let's welcome the next speaker, Dr. Abdullah Mustafa. He is from Ankara University Medicine Faculty, Turkey. Dr. Abdullah Mustafa has a membership in various associations, such as spine surgery section, orthopedics and traumatology department, Ankara University Medicine Faculty. His topic is facet impingement can mimic radicular pain. Short-term results of endoscopic treatment of facet impingement. Welcome.
Hi, dear President and my dear colleagues. And I chose a very specific issue in this meeting. And I will try to tell something about the foraminal stenosis and facet impingement. Lumbar foraminal stenosis is the most common reason of the failed back surgery. These stenosis components are herniated nucleus pulposus, hypertrophy of foraminal ligamentum flavum, and also osteophyte. L5S1 is different from the others because of some specific anatomical structures such as sacral area, iliolumbar artery, different facet joint from morphology, sacral tunnel, and iliac bone. What are the indications of the foraminal endoscopic decompression? If there is a radiculopathy and no adjacent central stenosis, and if there is a no fat sign in the foraminal area in the MRI investigation, and also the preserved foraminal height. And when,
excuse me,
sorry.
Professor Abdullah Mustafa, please share your PPT. Please share your point.
I share, but you can you see?
We can see the first PPT.
Oh, sorry.
The first slide.
This one?
Yeah. Okay.
Okay. Sorry. Okay, I'm starting first. And the indications of the endoscopic foraminal decompressions are radiculopathy, no adjacent central stenosis, and no fat sign in the foraminal area, but we want to preserve foraminal height. When the instability is present or the loss of foraminal height, we cannot choose the only endoscopic foraminal decompression. In the case of the instability or loss of foraminal height, we have to choose fusion. Is discectomy necessary for foraminal decompression, and when? Usually, the posterior decompression is sufficient, and discectomy in the elderly is dangerous in terms of recurrence. Straight leg rising test can lead in the differentiation of ventral or dorsal pathology. Also, we have determined a parameter as a coronal root angle. In this study, we find that if the L5 root in the L5-S1 foraminal stenosis below the 112 degree, we should decompress the ventral pathology also. You can see the measurement of the coronal root angle with the cauda equina. Facet impingement is my description, and I investigated my patients with facet impingement. The patient complains for back and buttock pain, and sometimes we cannot differentiate from the radicular pain as a root compression or as a facet impingement. This is the facet impingement. Especially in the scoliosis patients at the convex side, the superior articular processes growing up to the above vertebral transverse processing, and the standing position, it may cause a pain, and it mimics as a radicular pain. I will show a case with 47 years old female and left radiating pain. She has a lateral recess stenosis at 4-5 level, and also foraminal stenosis at the same level, left side. At the first stage, I decompressed the lateral recess with UBE, but her complaints continue to the buttock pain. The leg pain is disappear, but the buttock pain is present. And the second surgery, I performed an external foraminotomy with UBE technique. It calls also the paraspinal approach, but the external foraminotomy is more better. This is my short video. This is the line between the pars interarticularis and the growth superior articular processes. There is no space between the superior articular processes and the left transverse processes above vertebra. Now I remove off the tip of the superior articular processes, and there is no impingement now. I can use osteotome also in UBE. When I remove the facet impingement, I also decompress the foraminal region. Yes, this is the exiting nerve root and traversing nerve roots. Also the disc. Now there is no impingement with the SAP and the above transverse process, and the buttock pain is immediately disappear. Yes, you can see the perioperative and postoperative CT scan. There is no impingement now. I have 10 patients with buttock pain not radiating further down. I followed up at least 6 months, and every patient I perform preoperative diagnostic facet block. The foramen has fat sign in all of these cases, and the patient's mean pre and post JOA score is 11 to improve to the 20.5. My take-home message is we should differentiate with foraminal stenosis, and the facet injection can give information. If the pain can disappear, we suspect from the facet impingement. Patients can be relieved of pain without fusion in this technique. Scoliosis has a factor, especially the convex sides of the scoliosis. There are many facet joints impingements. It should be kept in mind, especially in patients who have back and buttock pain while standing. Another case, this is my last cases in these presentations. The patient is very elder and has very severe scoliosis. In these patients, I usually choose the stage surgery. Firstly, I decompress the contralateral lateral recess, and the patient has scoliosis, and we can visualize the 4 rules in the same portals. This is the internal foraminectomy. But the patient has relieved for leg pain, but still the buttock pain and back pain is present. When I check the CT scan again, there is a facet impingement at the right side L4-5 level. And I performed external foraminectomy with removal of the facet impingement, and the patient has relief for buttock and back pain. Thank you for your attention.
Thanks, Dr. Abdullah Mustafa, for your wonderful presentation. Now, thanks to all doctors' presentation in the morning. Let's check the question list now. Let's have a big discuss. There's a question from Professor Zhang Wei. It's for Professor Yu Keyi. What kind of screw do you use? Hollow or solid? Long tail or short tail? Professor Yu Keyi?
Okay, can you hear me?
Yeah.
Thank you. Very good question. So nowadays we use cannulated screws because it's easier. We can pass through the screw through the guide wire. It's easier, but we can put the solid one, the common solid screw, because we can probe the canal. We can tap, so it's a big hole under endoscope. It's easy to put the solid one, but it's hard to use the common screw because there's no long tail. So if we want to put the rod, so we'll need a new design pedicle screws. So this just mean like Dr. Zhang said, is a common solid pedicle screw with long tail, and maybe it's useful for spine fracture, because cannulated screw is have some disadvantage for either broken. So I think maybe we can use this technique to do the spine fracture and endoscope, to put a screw with a common solid screw with long tail, and even we can do this when we do some case, we can also do facet fusion. Not only put the screw, we can also use this approach to do the facet fusion. I don't think every patient, elder patient need interbody fusion. So it's maybe a potential use of this technique. And also, I think maybe in future we can use this technique in scoliosis patient to put the screw in the thoracic spine. So we can try more in the future. Thank you.
Okay, Dr. Yu, I have another question. I think it's a very good technique for insertion of the pedicle screw under the UV endoscopy. Is a great technique. But majority of the common solid, the pedicle screw is very short. So I think we need a design a common solid pedicle screw with a long tail. And another question is, how do you protect the medial feeders muscle when you perform this kind of the technique?
Yes, it's a very good question, because I just at the beginning. So first, I will touch when I make an incision. I will touch the lateral margin of the SAP. So I can feel it, the lowest part of the SAP and the lateral margin. So we will locate at this area as a initial space. So we only expose very little area, like the lowest part of the SAP. So maybe very little damage to the muscle, but we can try to preserve the most of the muscle, and there is we can control the breathing very well. Use RF radio frequency. So if we are very familiar with this technique, I think it's very it's a very minimally invasive way. Thank you.
Okay, I have another question for Dr. Motor. Why not choose the contralateral sublaminar approach for the first case? You say you can. The second case, I see the second case you choose the contralateral approach. Why not choose this approach for the first case?
Thank you for great question. My border is the for when I choose the external foraminotomy or contralateral internal foraminotomy. This line is the external pedicular line, and also the second, if the compression further from the external pedicular line, I choose generally external foraminotomy. And also if the patient has a facet impingement, I can't remove the superior articular process tip of the superior articular process via internal contralateral internal foraminotomy. This is my answer.
I also have a question for Dr. Abdullah. Just now, you briefly mentioned about the coronal angle of the exiting nerve root, about 120 degrees. Can you elaborate what is the angle that beyond which you will be doing external foraminotomy? When you do a coronal cut and you have an angle of nerve roots, exiting nerve root.
Yes. We have described this angle with only for only the L5-S1 level, because the L5-S1 level is different from the others. The L5 nerve root is going to the just to the sacral bone tunnel, no psoas or soft tissue, and the L5-S1 foraminal stenosis decompression results are not better comparing the other levels, and we aim to investigate why the results are not good at the L5-S1. Maybe the only posterior decompression is not enough, and we have tried to do description when we go to the ventral factors or dorsal factors are enough. And when we retrospectively investigate into the more than 50 patients with a microendoscopic technique, we saw that the if the L5 root angle with the cauda equina is getting narrower, we have to remove the ventral factors from the axilla of the L5 root, and the cutoff value is 112 degree.
Okay. Very interesting. I will look for your article. If you can share with us, it would be good. Yeah.
Yes, of course. Yes, of course.
How to? I have a question for Yuke. How to reduce the facet invalidation by your technique?
Yes, thank you very much. This is a very good question. We can choose the entry point on the direct view, because more laterally the pedicle screw, we can avoid the facet violation. So it's due to your experience, and you can choose the entry point. Maybe different surgeons have different entry point for pedicle screw insertion. So you can call it to your experience, but basically the more lateral the pedicle screw insertion, and the less facet joint violation.
I have a question for Dr. Malcolm Pastronji. I saw the location of the two portals is more lateral. Why do you choose these the portals more lateral? You want to deal with the central disc herniation or other situation?
I think Prof. Malcolm is not online. That's why
maybe.
Professor Zhang, which professor do you answer?
The cervical topic.
Cervical topic.
We talk about
Malcolm has told you.
Yeah, the location of the portals. I found his instrument can get to the midline. So maybe this is the reason why he chose more lateral the portals. I think. And maybe he's not online.
I have a question. I knew Professor Zhang has the experience to perform cortical bone screw by UBE. Yeah.
Yes. For the elder patient, especially the bone quality is poor. I will choose the cortical bone, the pedicle screw. But also insert the pedicle screw under the monitor of the endoscopy. I think this is also a good technique, especially for the elder patient.
Do you think which one is better, CBT or regular screw, regular pedicle screw?
For the young patient, I think the regular pedicle screw is good. But for the older patient, the CBT screw is good. But the patient had better not the rotator, the lumbar. So sometimes I think it's dangerous for the patient to rotate the lumbar for the CBT screw case. But I think we need to design the new type of the CBT screw, the cannular CBT screw, with the long tail. How to insert the root is a difficult procedure for the CBT screw under the UBE, I think. But it's easier for you to identify the position of the insertion area under the endoscopy. But it's difficult for me to insert the root, so I need to design a CBT screw with a long tail.
Thanks, Professor Yu. You can have a try. Have a try of CBT. I think CBT is much easier, maybe much easier than regular pedicle screw by UBE.
Yes, if we do the CBT screw, we must make an incision in the midline. The good angle of the insertion of the CBT screw is along the spinal process.
Yeah, and is less invasive.
We need more cases.
Yeah.
Yes, we can try in the future. Yeah, good idea.
We have 10 minutes to discuss.
Dr. Yu, I think maybe next time you can choose the more lateral supporters for insertion the pedicle screw. Then you can get a good angle of the abduction, then to prevent the facet violation.
Yeah. It's a thank you for your recommendation. Yeah, I will change. Maybe yeah. So
actually, I make horizontal cuts for biportal fusion, so that will allow me to put pedicle screw in a more lateral position. And also at the same time, we can start on the medial aspect. So it has more play in terms of pedicle screw insertion. I'm not sure whether that is good idea. Yeah.
Transverse incision may be good.
Transverse, yeah. So you can really put your percutaneous screw really laterally. Vertical incision looks beautiful and easier to remove the rod in the future if there's a revision. But if for that level alone, then I think if a transverse cut can get a very nice trajectory for pedicle screw.
Yes, so Harrison bone crest is very important in the anatomy, the landmark. But after I prefer to insert the teeth first, then I do the peculiars the pedicle screw insertion. But sometimes for the decompression site is not very safe. I think Dr. Yu's technique is very good. It can insert the pedicle screw under the monitor of the endoscopy, so it's very safe for the decompression side, the insertion of the pedicle screw. It is another advantage of this technique.
So may I have some comments with Dr. Henry's lecture? So here is a very good example for the spread of the innovation. So I do the uniportal endoscope and the biportal endoscope as both. So maybe 2 years ago, I start to use the biportal. So the biportal, makes the access of the endoscope easier compared to the uniportal. So we developed the endoscope spine surgery for maybe 30 years, but still most of the spine surgeons, they didn't do any endoscope spine surgery. So there's a very the big task of the UBE or biportal endoscope is to improve the rate of the spine surgeon to do the endoscope surgery. So I think Dr. Henry's report is very good, because in China also we have this kind of problem in the countryside. Not every hospital had good facilities. So, but the UBE, you can use UBE to endoscope spine surgery with less expenditure. As I showed this technique, you can use robotic surgery or navigation. It's developed by the United States, but it's very expensive. So we need the third way to improve the minimally invasive spine surgery. So it's my opinion.
Yes, the cannulator, the pedicle screw is very expensive in China. So the common regular pedicle artery can reduce the cost of the patient.
Thank you, dear friends. Thanks all the doctors. Thanks for your wonderful sharing. And thanks for all the attenders. Then it's time to have a rest. It's coffee time. We will start after 20 minutes. The live surgery will start after 20 minutes. So it's time to have a coffee. See you later.
Thanks. See you all. See you all next time.